judges and audience. My topic for today is a case report on the efficacy of modified electroconvulsive therapy, ECT, for behavioral and psychological symptoms of mixed cortical and sub-cortical vascular dementia with Parkinson's. What is dementia? It is a neurocognitive disorder characterized by impaired memory, language, social, cognition, and executive function. It can also have behavioral and psychological symptoms called as PTSD, such as agitation, depression, and psychotic symptoms. ECT is reported previously as an efficient approach to reducing agitation in dementia patients, which poor response to conventional interventions. It can also help motor symptoms of Parkinson's disease, which has been proved in certain studies. And hence, we report a case of a 60-year-old diagnosed with mixed cortical and sub-cortical vascular dementia with Parkinson's disease, who responded to 6 sessions of bifrontal modified ECT. The patient came, a 60-year-old male, with the outpatient with symptoms of recent memory deficits, auditory and visual hallucinations, of a friend going in and out of his wife's room, along with the delusions of infidelity for 4 years. Wife reports of patient being more aggressive towards her and accusing of her being unfaithful. Family also reported of memory disturbances, recollecting his day-to-day activities with gradual decline in social or occupational function since 4 to 5 years, and associated worsening following a cerebrovascular accident, a CVA, in 2020, post which he also started to have guided amnesia, fascinatingly, and his first stage. The patient is also hypertensive, diabetic, and had a cerebrovascular accident along with an ischemic heart disease, which was diagnosed 3 years back. The patient is a chronic smoker from 12 years of age, who smokes around 2 packets of cigarettes per day. Family history suggestive of OCD and a possible psychotic or mood disorder in first or second degree levels. On carrying out a general physical examination, grade 3 clubbing was present and the patient was overweight, the BMI of 25.9. On CNS examination, upward and downward gaze restriction present, reduced right nasolabial fold prominence with right side deviation of the mouth. Cogwheel rigidity and intention tremors are present in bilateral upper limbs. Power of 4/5 in bilateral upper and lower limb. Bradykinesia, fascinating gait, forward propulsion and decreased arm swings were noted, and scanning speech was also noted as well. On carrying out an MSc, mental status examination, attention was aroused, not sustained. The memory was impaired. The thought, the stream had a reduced volume and monotonous speech. Delusion of infidelity, depression, and occasional visual and auditory hallucinations were noted. On carrying out investigations, the remaining investigations of CBC, LFT, RFT, and serology were normal. However, an MRI showed chronic lateral infarcts in bilateral coronal radiate and basal ganglia, chronic small vessel ischemic changes with age-related cerebral atrophy. On carrying out a Hindi mental status examination, the score came out to be 21, which brought us to the diagnosis of mixed cortical, our case of mixed cortical and sub-cortical vascular dementia with vascular Parkinsonism. And of course, as I mentioned, the patient had tobacco dependence syndrome on continuous use and an old cerebrovascular accident causing eye paralysis. For this, the patient was started on levodopa 150 mg and carbidopa 37.5 mg and trimethyl benzexole 6 mg in divided doses. For the psychotic symptoms, he was tried on ibuprozole 20 mg and duracillin 80 mg, which actually caused the worsening of his Parkinson's symptoms. Due to the continued aggression and need for response, he underwent 6 bifrontal modified electroconvulsive therapy with good improvement in psychotic symptoms. Currently, the patient is reported better on a 1-year follow-up with minimal symptoms of trifluoperazine, quetiapine, along with levodopa, carbidopa, and trimethyl. So this case report actually indicates that ECT is a safe and effective option, reducing agitation, lowering psychotropic medication usage, and enhancing the overall functioning. According to the literature, improvement in BBSD is often seen after 3 sessions, with a median of 6 sessions required, which is similar in our case. I would like to end by saying that the stigma associated with ECT is a major barrier for its utilization, and further prospective studies are needed to evaluate the role of ECT in its safety and management of dementia and symptoms of personality disorder and Parkinson's disease. Thank you so much.
The administration of this ECT in this particular case, what would be the years and what is the main concern as such?
The main concern is that the patient actually reported constant fear of electric current going inside them is what stops the people from taking any CT.
Any cognitive issues that noted after the administration of this?
For our patient, the patient is doing well after 6 sessions of modified CT.
So, what kind of placement options of electrodes are there? And should you want to choose something else because of what she's doing and having possibility of cognitive symptoms and vascular cognitive profile after these things? What options are there as per literature or your?
As per what I have read, ECT is only given when pharmacotherapy actually fails. So,
I'm asking you what placement. Now you said you choose bifrontal electrodes. What are the other electrode placements possible and what could possibly be more used in people who are electrode placements?
so there is a unilateral ECT as well, where the current is delivered only through the one side of the brain, which delivers seizures to the entirety of brain, as compared to bifrontal ECT, which is able to do both sides of the brain. And as per what I have studied, ECT will only be given if pharmacotherapy fails. So even if any CT fails, we choose to go back to